Okay, now for part 4. So up until now, we've talked about the individual patient. Now we'll try to take a broader perspective, talk about how to manage flow, how to manage the general, more systematic system aspects of being an emergency physician in the emergency department when it comes to patients. So we have talked about these two groups, and now I want to talk about all of this. The box that we live in every day, and the box within the box. What is outside this box, right? The system that we're in, and how we can or cannot affect all of these things, and then how we manage to see these, but also think about there's also all of these outside as well, and how we plan for doing that as best as can. I'm no expert in this. This is something that all emergency physicians to some extent know by heart because we have to work through all of this. These are Jeffrey Braithwaite's words that many people in medicine in general knows about complexity theory and system thinking by heart because it's something that we just live every day. So it's intuitive to us. But I'll try to show you some links and show you some of these things that I think emergency physicians, when you're getting into different positions, non-clinical positions, in like groups that try to improve things and implement things, I think it's important to know some of these things. So and also when we are getting critique outside of emergency medicine, I think some of these topics are important to know about. So here we go. So I started to talk about the time critical conditions down here, right? This is what our focus up until now has been, with a little bit of numbers needed to treat equals 1, the compassionate care part. But now we're going to talk about this, like every time we treat one patient, we're taking time from another, which might, like, how do we not get stressed by that? How can we actually balance this? And yeah, we'll, outside of performance under pressure and all the non-technical skills that we just talked about, we might consider the individual. Sometimes you have to, yeah, with time you'll get better at knowing who to treat acutely and who you have to spend a little more time on so that they don't return. So it's kind of, you shouldn't spend too little time. You shouldn't spend too much time. There's a Gerben Kaisers and Fadovich, who are some great professors of emergency medicine in Australia, have made these series of articles about like how do we manage these things, the inverted time curve in emergency medicine. Like you can't spend too much time, you can't spend too little time. How do we manage this Goldilocks zone? And it depends on the shift, on what kind of day it is, what all these things. But I think the important thing is that even though we should always try to convey compassion, try to convey that we're trying to help. So let's try to start there. So just to summarize, this numbers needed to treat equals 1, meaning that every time we see a patient, they should be better off from our meeting than they were before our meeting, right? That's the purpose of being a doctor, I think. That's one of the main purposes of being just a general doctor. And that is something that is carried on into emergency medicine as well, right? I've talked a lot about this in this video, and I have some blogs on it as well. If you want to check out the links, then please do so. But one of the things I think is really like to show this just in a graph way, compassionate care is very much like, it's not what you say or do, it's how you make people feel, right? So it's not necessarily that you didn't do this or didn't do that, or it's more the way that you do all the things. It's all the non-verbals and paraverbals and verbals. It's the way when you walking in between patients, when someone is is actually talking to you, and you maybe don't have time right now, but you come back afterwards to see whether they got help or not, like so on and so forth. Like it's a way of being. It's your, and it doesn't, if you don't feel good in your life, if you don't feel good at home, then sometimes these things carry over into your work life. So it's all of what we've talked about. How do you like kind of build yourself up to do this, or how do you grow into this? It's lots of the podcasts that I've talked about in compassionate care talks is exactly about these things, like how do you start with yourself, like your own stoicism or mindfulness, or your own kind of to build up to this. And it is something that it's teachable, or like it's, you can learn these things, or you can always become better at these things. So lots of these like ways of thinking about it. That's what I kind of tried to convey in this lecture in general, to just get these idea out there. So, but what I mean is like where the patient is now. You see the patient here, right? And oftentimes we don't think about our words when primary care has sent this patient in for the second time this week or whatever. Like we might say something stupid like, "Why did the doctor even send you here?" Or how, or maybe something aimed at the patient, like, "You shouldn't have come during the middle of the night. That's stupid." Or like maybe we wouldn't say this bluntly, at least not if we're well rested, but we might convey it through the way we like the things that we don't say to the patients, the way that we act towards the patients, the tone that we have, and all. So even though we might not, even though we might be able to keep a face of politeness up, and you can to a certain extent fake it till you make it, at some point you will, like, the mask will crack. And I think it's important to like search out those deeper things within yourself. Why do you think that the patient is like, why do we think that we sometimes make the patient worse off by either saying something about their own doctor, saying something about their way of seeking out care, and so on, right? Or the way that they think about themselves or their medical situation or whatever. So the things like do no harm. I mean, I don't like that term because every kind of treatment I mean, with all treatments, is also our verbal communication carries a risk of harm. It will always carry a risk of harm, but our intention should be to never harm the patient. Like the overall benefit harm ratio should be positive, right? So first 10 a.m. Justin Morganson has written a blog about this as well. Like he doesn't need like the first do no harm or prima non nocere kind of thing either, because it's just, yeah, it kind of carries a notion that like that is a like it's you could either go harm or you can go benefit. Like it's not on the same menu. And yeah, I just check out his blog. He's saying it's much better than I am. But right. And I think nocebo is something that we like. Compassionate care makes the placebo effect much stronger, and the opposite, nocebo effect, the way that we act, can make people sick, right? So our communication, the way that we convey and carry ourselves, convey our message, how we show we care, this one up here, how you make them feel, is such an important thing. And you can easily go in a nocebo group if you don't like have your heart with you in these things. And even if you do, but you don't, like, you miscommunicate. So you try to get better at those non-technical skills there. It's really important. And if you've been the patient, you know. All right, how do we do it, right? So I'm not saying that we should get the patient from where they are now to the cure every time. It's like the old Hippocrates thing, like we should seldom cure, always nurture, or always linder, right? So we can always give them some comfort, right? And that might just be sitting with them and talking a little bit with them, listening to their story, and giving them a risk assessment using some of these things, tools that we talked about in the communication bit: validation, expectation management, compassion, and so on, right? And sometimes we do get them to a cure, but that's not our main. We just need them to get them to the next step, right? Here's the plan. Step 1, 2, 3. If you get sick, then come back to us, right? So like just having a plan, having someone to listen is often enough, and it's therapeutic in and of itself. Okay. And this is just where the quote is from Bernard Lown, who talked to a Siberian doctor who asked, like, what's the main purpose of being a doctor? And he was told by the Siberian doctor this: every time a doctor sees a patient, the patient should feel better as a result. And I think that is numbers needed to treat equals 1. And the NNT equals 1, I actually don't. It's not myself who has invented that. I first heard it by Ken Milne in one of his blogs. So check that out if you want what I think is the primary source for it. Yeah, and yeah. So as we said, every step counts, right? So it doesn't have to be big steps in the right direction necessarily. We can't do that with everyone, but a little bit. It can be everything from saying sorry for the wait, that's validation, sitting down and letting them tell their story, as we said, writing up a plan on the paper that they agree on and understand, giving them a blanket or a juice box, and so on, right? Time critical conditions is our main thing. Sometimes we can also do the customer service thing and try to inform them about this. I mean, we all try, but it doesn't always happen. And we shouldn't over-explain anything. We shouldn't be too. We talked about this as well in part 1. We shouldn't be too confident in our own ability to diagnose musculoskeletal pain or gastritis. I would rather give the patient a symptom diagnosis and then follow them up for a definitive diagnosis if they need it by gastroscopy or whatever, right? But if you some of the books that I didn't talk about is like the diagnosis culture that we have, and overdiagnosis, and the problems with having a diagnosis and becoming a patient and all these things. Lots of, like, I think the Danish doctor called John Brodersen has made a book recently about this as well, about the Diagnostic Society. The DSM-5 author, I can't remember his name right now, but has also made a great book about this, about diagnosing people in unnecessarily. Susanna Solomon has talked about this in her overdiagnosis book as well. Check out my overdiagnosis video for more on that. Okay, so that's the numbers needed to treat equals 1, and the zero-sum game. That's what we're going to talk about the rest of the time here. So, complexity and criticality. So before we head into some general clinical advice for both specialists or consultants and residents alike, we need to know a little bit about these theories. All right, so what's the difference between simple, complicated, and complex? Because we use these terms interchangeably, or at least complicated and complex interchangeably in layman's terms oftentimes. But in this kind of complexity, kind of sciencey thing, we would use simple as something that you can make you can make a recipe, and then a machine could do it, or an algorithm, and the machine would be able to make the same product each and every time. There might be skill involved. Like, it's not a skill-less field, but a machine would be able to do it 90% as good oftentimes. So that would be like something that can be made by a recipe, right? And you can do an algorithm, and you can make a machine do it. Kind of, that's a simple thing. A complicated thing would be like going to the moon, like making the rocket to go to the moon. It is complicated because it's several recipes on top of each other and interconnecting, but it's still something that is doable, and robots would be able to do it at some point, right? Complex things, and as opposed to the complicated and simple ones, are things that, even though you do the same thing each and every time, like raising a child, even though you give your child same kind of food, the same kind of time of day, the same amount, and so on, you will not get the same results each and every time. Complex things cannot be ruled by algorithms. Some pieces of the complex thing might be ruled by algorithms. Like if you're going to bed, you might have a routine for that. But then there has to be some kind of adaptability in that system. You need to be able to, if it's going the wrong way, you need to know what to do. And I guess you can say that for all of these as well. But I guess this involves much more of it, at least. Complexity in that way is something that cannot be followed by our algorithm. We'll talk about more about complexity now, because most of our what we're doing, like the systems that we're working in emergency medicine and in medicine in general, these are complex systems, or complex adaptive systems, I think they're called. So let's try to go on and talk more about those. And again, I'm no expert in this, but some people who are experts have made videos. And if you want to like do a free kind of overview course in these things, there's this YouTube channel who talks that shows a lot of the key aspects about complexity adaptive theory, and how it's different from like linear thinking. Jeffrey Braithwaite is a amazing anthropologist, I think, Australian anthropologist, who's made for maybe 20 years, I think, articles about complexity thinking and implementation in in medicine in general, but also in emergency medicine. And they made this in 2018. He made like a podcast with BMJ, and a kind of like review article on how to implement things in medicine and what we're doing wrong. These are some of my sources for the thing that we're going to talk about now. Kevin Fong and Martin Bromley have made some SMAG appearances, and Martin Bromley has talked in other ways as well about system thinking and system design, so that we do the right thing, or it's easy to do the right thing. And Kevin Fong talks about this graceful degradation, which is an important aspect of complexity. So, St. Emlyn's has some amazing podcasts and blogs on complexity, and try to check those out. And yeah, just another one from St. Emlyn's, and another one from St. Emlyn's. Okay. Some of the features of a CAS, or a complex adaptive system, is that the sum is greater than its parts. It creates this kind of like, usually in a complex system, there's many moving parts that together creates something that is more than its parts through a phenomenon called emergence. I can check out these definitions yourself. I'm no expert in this, but so when emergence occurs, it's kind of like something that's it's something that kind of defines these complex systems, that they're no longer linear. Like they can no longer be ruled by algorithms. They're too big. There are too many moving parts, which makes them in many ways stronger. They can do a lot of things autonomously or semi-autonomously, but it also makes changes to these systems harder. And they're also kind of unpredictable, right? So like I will again think about your child or child upbringing. Because it's not linear. You can't do the same thing each time and expect the same results. They're adaptive and dynamic, and then within this there's a certain amount of uncertainty, right? And some of this uncertainty is irreducible. The changes that you need in this system, if you want to do any change, it has to be from bottom up, not from top down. You can't say from the CEO to say like, we need to do this, and then think that will be done. It's like putting I often think it's like an ecosystem or a system of ants. Like think about a circle of ants where you just put a small a small drop of water or acid or whatever into the area like in the middle, they'll just move around. Like they will just move around it and then just to continue doing what they were doing, even though you like your septic protocol, your new sepsis protocol, or your new 4-hour rule to like, they'll just move around it and gamify it, right? They might like, and it's not because we're evil or stupid or lazy or anything in the front line. It's more like we have other priorities that we try to make people survive and make workarounds. And usually these droplets from above are not good. They're just making things worse because they don't understand what the first thing is about working on the floor. And it's not to be contradictive. It's just it doesn't work. It just simply doesn't work. So it has to be from the ground up. There has to be ideas from the floor that are implemented, and you have to have some kind of feedback mechanism. It has to be flexible. It has to be durable, so that even during night shifts, we can withstand high flow. All of these things. We'll talk about it later. There are some key words in these kind of thinkings: adaptiveness or flexibility instead of algorithms. Butterfly effects. So one effect might have unpredictable effects another place in the system. Emergence, many moving parts. And it creates these that's what creates this kind of complex system. You need feedback loops, and you need like part of the adaptability and flexibility. You need like feedback to know. All right, self-organization, like lots of these complex systems like an ant nest, or like you can't have one person or a few ants that control everything. You have to have some like the ground people must have, or the ground ants must have some autonomy. And we talked about it in the culture code, kind of like they need some kind of priorities that they have to build from, but they have to be problem solutions. They have to have agency enough to be able, or autonomy enough to be able to like do it themselves when they come to a problem. If they have to go up all the way to the CEO every time, it's impossible, and nothing would get done. And you have this thing that we'll talk about in the next slides called self-organized criticality or critical threshold. Why is this all these things? Why this is important in the emergency department? These things about complexity theory. Well, we are a self-organized unit, right? And we need to think like if anyone thinks anything else about ours, or try to change these things, it's unchangeable. It's just how it is. So you might as well like go with the flow and rule accordingly. We need one of these things in these blocks is talking about repairing itself. So we often talk about innovation, and we need this and this and this. What we actually like, and from a new public management view, lots of like workers are just interchangeable or changeable. Like you can change one person from another and you'll get the same product. That is not the same. Like we know that someone who's worked in an emergency department for 10 years does a lot of things that are invisible to the people measuring things, all these important unmeasurable things. But as long as we keep measuring things and keep filling up all of our time with measurables, then we fall for the McNamara fallacy. Like you think that all things are the only things that are important are measurable, but what you actually are seeing that if you're filling all of your space up with measurable things, like just taking up all of our energy, making small droplets from above, we need to just try to work around it and try to repair it so that people can be saved, right? That's I guess it's a bit unnuanced, but it is a lot of the things that complexity theory is talking about is the things that we're living through each and every day here, right? And it comes back also to Goodhart's law of gamifying metrics, right? When a measure becomes a target, it ceases to be a good measure, right? So once the 4-hour rule became a target, it ceased to be like, it might have been a good measure at some point, but it's not anymore, because we just like what started like if we don't do it smart, if it's not from the ground up that we kind of know that this is an important target for mortality and all, which it wasn't in the beginning, then we just kind of gamify it. Then we just say, like, we draw a line here and say that the department is just in this corner of the emergency department. That's the department, or like you can see. Because when the beds are moved there, then they're in the department, quote unquote, and you can stop the clock. All right, so you will just try to gamify the things to make things work. All right. So it's hugely important that, like, the experience cannot be measured, and it's so important. And we often do invincible things, repairing ourselves along our day and making things like go well. And that's often, like, all of these butterfly effects are often the difference between a good shift and a bad shift. When you have someone experienced and someone who knows their stuff, right? And it's unmeasurable for the system, but we know when you're working. It's also about one of the things that are important from complexity theory is that we have to build with capacity for search, like buffer. If we come back to this in the self-organized criticality, if we work at criticality like 100 or 110% all the time, then there's not enough capacity for when things like heat up, because we cannot move, and it's a quite frail system that quickly will collapse by just one or two extra patients, right? So graceful degradation is Kevin Fong's term. Don't plan for optimal days. Plan for nights and highest pressure, like what fails best. So it doesn't have to be the best plan. It just have to be the least worst plan, or plan that fails good. I mean, it might be that you don't have to empty your emergency department each night. You just have to have some buffer during the morning so that people can come in where you know that people are seeing those non-sick patients. It's not a perfect system, but it's a system where no one dies, right? At least, hopefully, not that many, at least. So I mean, so it's we have to do what we can with our resources, and sometimes the old ways or the things where you built in 3 or 4 or 5 redundant mechanisms for safety are good. So because they won't die, even though the system doesn't work perfect. It's something that is robust enough so that if it fails to a non-catastrophical level. It will not be a black screen, right? It will just go back to and restart. Go check out Kevin Fong's lecture for details on the graceful degradation thing. One of Braithwaite's points or important take homes is that we're not good at implementation. Like, we might say, this is a great guideline. We should just send out an email. On Monday we will be doing this guideline, and from then on. That's a bad plan, right? It's from above, so it's these like tiny droplets down into the ants, right? But it also takes, like, implementation is complex. It has to come from down up, and it has to have feedback built in and test like small checkpoints to see whether it works or not. Okay. Design for maintenance, yes, and it's often overlooked. We talked about, like, the experience that we carry and repair mechanisms and all. Check out the second inlands block for that. Be proactive, not reactive. Yeah, we have to do something when we're working. We have to continuously think about like how close we are to criticality. Because once we hit criticality, like it will go fast downwards, right? So yeah. So, and this is from Psych Safety. Here you have, like, think about, you have a like, if the emergency department or from like your local emergency department is like a hill of sand. Every time we do, like, unreported near misses, unsafe shortcuts, missed maintenance checks, it adds less flexibility in the system. right? And these, like, why don't we do all of these things? Well, because of missed times, or we don't have enough admin time, or we don't have a culture where it's awarded to do these things, like so on, right? All of the things that we talked about, non-technical skills and cultural, building a good culture. And then you'll have an emergency department that is as really close to the critical point or critical threshold all the time. It's called SOC, right? And you just need this tiny new grain of sand to get a major incident. So right now, I've worked in a couple of places, right, where there might not be too much inflow in one part of the emergency department, and then I'll give you the example. So in our emergency department, we've had like we have a medical part and we have a surgical part, and the medical part has always been prioritized in such a way that you have maybe you have 3 or 4 senior doctors there all the time, or during nights you have at least 2 that can come down from upstairs, and who are often flexible enough to do so, and you have 3 others working, right? So residents, and even though there are high inflow there, it's just built with a buffer. You have more buffer. You can get more resources in there very quickly, as opposed to our surgical emergency department, where I mean, usually it's staffed with somewhat unexperienced doctors who has a variability and experience, and you don't have that many resources. It's only you guys who are there. You don't have any surgeons who come down usually, because they're operating, and the system is not designed for it. And then you quickly get like this, and you get fatigued because no one wants to, like, no one has time to even reinvent the wheel, because you're kind of trying to just breathe air. You're drowning, and each shift, and you're just trying to survive. You're not, and then people keep working there because you don't have enough staff and so on. So it just becomes this high mountain of criticality, and you don't. So even though on a day in the surgical emergency department where it looks like, oh, there's not that many people there, I mean, you can calculate that in different ways, right? You can calculate it on people, like patients per doctor there. Usually it's the same inflow then, but because of the small buffer in that part of the emergency department, and the small capacity for extra inflow and all, then it's a much more it's a part of the emergency department in our place that is much closer to criticality, and therefore it's much more fragile. Not much has to happen before everything like there comes, I wouldn't call them major incidents, but minor incidents every now and then, right? Okay. So what can we do? Well, to make the sand bunker less, well, self-repair, plan with buffer and slack. Like you have to plan for capacity of 70%, not 100%. So that means both extra staff, extra beds, extra, like, everything. And I know this is something that the new public management thing don't want to, because it looks bad, but it's just, I mean, if we want to avoid crowding and all of these things, that is probably the solution to things. And it will make a better work environment for most people. And I'm no expert in this. I don't know nothing about economics or anything like that. But I do know that that's probably the solution. Adaptive design, agencies of people on the floor, and so on. What is the wrong thing to do? Top-down decisions, and linear thinking, where you have like this algorithm without no flex in it. Not appreciating self-repair efforts, like the experts on the floor trying to do non-measurable things. No bets, and you have boarding or crowding, and all the algorithms and plans, and so on, right? Just a quote from the St. Inlands, like ED wait times and length of stay data often follow power law distributions. Yeah, hospital occupancy above certain threshold around 85 to 90. We talked about 70% recently. 85 to 90 leads to dramatically increase in ED boarding. Yeah, because you're getting closer to criticality that way, right? So not a lot of more people have to come through to make the entire system collapse. That's why just a few people out, like when you're working at 90 or 100%, then not much has to happen before everything. Just seems like a really really bad day, and that does and then it just goes from there, right? It's not linear. It's not linear. It's the power regression, and it's just yeah, these few grains of sand can make it go from good to really really bad in if it's close to criticality, if you're not building with buffer. Small increases in ED census can trigger disproportionate increase in wait times. That's the same thing when the system is near critical state, because there's no buffer. You can't, at some point you just spent. It's like running the marathon and suddenly you hit the wall. Even though there's only maybe 5 kilometers back, like proportionally it's way less, but you've hit the wall and you can't, right? So you just work much more ineffectively from then. And Patrick Crossbury would say emergency medicine is the laboratory of failure or error. We work in this system, and like the holes in the Swiss cheese becomes much bigger when these things happen, right? So it's just a system that is higher risk of failure, and the individual doctors, nurses assistants, everyone working has a higher risk of, like, are in general in a higher risk of making mistakes or making errors, or like whatever you would call it, not because of themselves but because of these complex things. Check out Simon Bromley's lectures on YouTube about these things, where we have pushed our systems near 100, 120, 100, 130% of the workload and normalized it as the new normal. We're saying that the new normal is these criticality points, like or the new normal is these sand castles near criticality, because that's the normal, and we don't know what happens when they just collapse. It's crazy. Yeah, check out this blog about self-organized criticality, SOC. Flow and crowding. So all of this complexity takes us back to another important concept about flow and crowding, and lots of blogs about how like crowding affects emergency medicine. And I take a lot of a lot of the things I'm talking about, I'm taking from these blogs. There's a great like waiting to be seen blog by Howard Owens, part in like in maybe 20 or 30 series on EM cases, and this just it goes into the niches of these, like patient per hour, how many patients do you have to see, is that even a good number, and so on. Like why should we measure things? Stimulus podcast has these things as well, and along with these blocks here. Royal College of Emergency Medicine has a crowding task force, I think, and they've made some great papers on it as well. Yeah. Okay, some definitions about this. So crowding is a situation where the number of patients exceeds the ED's capacity, compromising timely and efficient care. This is the ARCHEM definition. Sorry. And then there's another term that is important here, which probably is the main cause of crowding, and that is access block. Inability to access the care you need when it's needed. This can be considered as the wrong care in the wrong place by the wrong provider at the wrong time. So it's, if you know the Lyon principle, which is the best, like the right care at the right time, that's the opposite. And this is from EM cases, the access block thing. And then you have a subgroup of these things called boarding. That's when the patients who need hospital admission but remain in the emergency department because no inpatient beds are available. So we often talk about these things interchangeably, but crowding is kind of when you have all of these patients coming in and it exceeds our like buffer capacity, right? So people are lying in the in the hallways, and we might not have enough nurses and our staff to see every doctor or every patient at every at the times that they should. And then and boarding, which it looks like the same, right? And it's just a subgroup. That's only when they're at the access block is towards the upstairs. I'll also say this: like crowding and access, crowding is a total entire system problem that usually it crystallizes in the emergency department, because we are the entrance point of the in most systems, at least where you can come in from the street, right? And we are the default mode for all patients becoming sick or from outpatient clinics and so on. That's one of the arguments that we shouldn't be all that. We shouldn't be everywhere, every time, 365 days a year, 24/7. We shouldn't be that. Maybe. So that's the discussion that's going on right now. Should outpatient clinics take their own patients and so on? There's lots of solutions to these crowding things, but I will say this: crowding exists in the entire system. It's just most evident in the emergency department. We're not the only ones suffering from this, and it is a total problem in the entire system. Accessblock is the main perpetrator, is what the experts usually say. So when the patient can't seek out their primary care physician, that's accessblock. Then they'll go to the next level, which is our place, emergency department. When we can't admit the patients, that's accessblock as well. That causes boarding. So yeah, and one of the main things we have to say about crowding. Why are we talking about crowding? Well, crowding is evil, as I think Simon Carley and Arkham would say. Crowding is evil, and there's lots and lots of studies showing that there's a higher mortality, higher error rate, less work satisfaction, so on. Crowding is evil. We should reduce it at all costs, or maybe not all costs, but most costs. And we talked about criticality and all. We can design ourselves out of many of these things if we wanted to. But it is a complex problem. It's a problem that is all over the West, and it's mainly emergency departments can do what they can within their own department to organize some of the things, but most times it's a political decision that needs to be made. So it's usually decisions outside of the emergency department that makes the crowding worse. And sometimes, just an example of this is Nils Blocks, who talk about the beginning of the system, meaning primary care and emergency department. We count the time in seconds and minutes, when as the end of the system, which is rehabilitation and usually municipalities and all home care, they measure it in hours and days, and you see how there's a bottleneck recreated somewhere in that system then. And I'm not saying that they're doing a bad job. They're also poor resourced, and it's yeah. So we'll go into this. So why is crowding important? We talked about that. Why is there crowding and access block? Well, we talk about this when we talk about crowding, there's this input, throughput, and output. And probably the best video I've seen on this, a small short video, is from called from the King's Fund on YouTube, is a British one. An alternative guide to the urgent and emergency care system in England. It talks about this, the input. And lots of factors here. I'll just show some of them, the patient expectation and complexity. People are getting older, we have a higher input, and the patient that go into the emergency department have more conditions, more problems with them, and they have more medications. They take more time. We also might have the problem with Lyon principle, and even Illich would, the philosopher and priest, even Illich would say that we cannot, we have screwed ourselves over. We not only in medicine but in all fields of living, we are castrized in some way. We cannot do what we are supposed to do to actually live anymore. We don't know what to do when we become sick. That's one take, right? We don't know what to do if we have to fix our floors at home, maybe either. Different things of living has become outsourced to institutions, and that's convenient, but also has made our lives a little less like we will always in a globalized world be dependent on each other, right? But even Illich's argument, as I understand this, like we have gone too far along that lines in some areas, and for instance in medicine, yeah, and that means like we seek day one often when something is wrong. But that's also we have a system that like people don't have time for these things anymore, right? Or the optimization society, and lots of discussion there. I won't go into the political stuff because I don't know enough about it. But so then you have throughput, input. How much people are coming into the emergency department? If we're seeing is this from the emergency department standpoint, throughput. So if you have staffs, like how quickly can you sort of move the meat in a non-compassionate care term, like so how quickly can you like assess patients, get them like to a point where you can make a decision and get out or in or disposition, right? And the problem is if you cannot follow up people, then you have to work them up in the emergency department, right? And that's a problem. And if you don't have enough experienced staff, and lots of things, lots of factors go into the throughput thing, right? And output, that's the access block part, right? So not enough bits, not enough people to admit, not enough, like we talked about that access block thing. There are myths of crowding I just wanted to go through. Easy solutions exist. Well, it's somewhat yes and no. It's a complex system and multifaceted, but also some easy solutions do exist. And a complex system doesn't necessarily have to have hard solutions or complex solutions. Usually, from the ground up, there are some great ideas, and sometimes we just miss those. So we need to listen to the people on the ground to see what can be done. But it's also a complex system with wicked problems, as it's called in complexity science, where there's not a normal solution. It has like the entire system has to be built into it. Crowding in the ED, because ED physicians are lazy, is because ED physicians are lazy, stupid, or the ED is worse than other parts of the healthcare system. Well, as I said, crowding is a problem in the entire system, and it's distilled or crystallized, like most evident in the emergency department, because we're the entry to everything usually. Is the patient's fault? No, it's not the patient's fault. I talked about even Illich and the threshold to seek, or why we seek, but mainly like there's a great waiting to be seen block about this, and in general people try all they can to not go into the emergency department, so we should not be mad at the patients at all for this. It's just, I mean, I'm not saying that maybe a few, but I mean in general it's not a good standpoint, for a therapeutic standpoint to stand on. And usually it's like if you ask people, they've tried and they have their reasons. They have their reasons to go there usually. And it's just sad that the system is guiding them towards the emergency department and they don't have anywhere else to go. That's the problem, right? That's the access block problem. So it's more of an access block problem than it's the people's problem. And what works at one place works at another. Well, the problem with these things, like there's also a yes and no answer, right? So you can be inspired by some solutions from other places, but a lot of these things, because it's complex systems, as I understand it, it's very local, and a lot of the things within the emergency department you have to find the solutions in your emergency department, but you can be inspired by others. Models and solutions. Okay, so one of the models that is important to know about, this is from the Danish, I have the reference in the next slide, I think. This is what you call the whale, when people seek. This is all over in most, at least Scandinavian emergency departments, but I also think in outside of Scandinavia. It's called a whale because it has like a kind of whale shape, as I've drawn here. My son would love this. All right, so around midnight, until 6, 7, there's not a lot of flow. Then during the morning from 6 until 11, the flow goes up, it accelerates, and it stays high through the evening. And usually the main problem in many emergency departments is that this hump here, the evening part, there's not enough doctors to actually get rid of this part. So that means that there's a lot of people waiting during the nighttime when there's less staff, and then on top of that, there's still this inflow, and sometimes it's higher, right? It's an average this, so but there's still this inflow, and yeah, so that's why in our emergency department and in most emergency departments in these open systems in Stockholm at least, you'll have 10, 20, 30, 40 patients, maybe more sometimes, waiting in 10, 12 hours, all during, like, you have, they were usually assessed first triaged here, and then you're seeing them at 7 or 8 in the morning, maybe 9. You might have a lot of people boarding on the bad days, and lots of bad days, because as we talked about criticality, right? We're building and designing towards criticality, so we have a lot of bad days, quote unquote, not average, because it's not an average Bell's curve, it's a power curve. All right. So yeah. You'll always, like, at least here in Stockholm, there's a pattern where you, like, a lot of people seek a lot, or for complex reasons and butterflies effects, I'm sure. After long vacation periods, like a week or more, then we will see a high flow the week after that, once everything starts up, right? You also see a higher flow during Fridays when the primary care physicians close down. No critique of those, but like Glaucoma Flecken, the comedian ophthalmologist on YouTube, has made this great video about this as well, where he's like, is it just Friday, or is there something wrong with the patient, or is that why you're sending them in, or is it just Friday? So we do see a lot of during Fridays when when people have to go home to their families. I understand then we see more, right? So there are certain variations to this very general pattern, but usually over time it follows this whale pattern. Okay, and here it was Hållningspapier 2024 from DASEM. That's the source for this, and then here from Eklund. And here we see, like, when it's low and high, it still follows this whale pattern. This is from KU University Hospital. So when you have a high flow and when you have a low flow, it's kind of the same whale pattern in all of these days, right? This is from Eklund, Swedish article from different emergency departments in Sweden. Same whale pattern. Okay. Yeah. Again, this is just another. We're talking about models for understanding crowding, and here's just another model. We could talk about this already, like input, throughput, and output. Here's just Danish crowding can arise when when there's too many patients on their way in, as opposed to the resources in the emergency department. Throughput crowding can rise when there's too many patients, as opposed to the resources in the emergency department. Within the emergency department, and output is the access block problem. There's no beds available. Here is the Arkham crowding paper, and their model of it. It's the same thing with number of patients, series of patient presentations, and number of patients transported by territorial emergency services. They go into these sieves. And work of emergency department, medical examination, blood tests, and so on, blah, blah, blah. And then prolonged waiting times, delayed patient entry. And then we get, so these are crowding input factors, crowding throughput factors, crowding output factors, how good are the doctors that are there, like how many beds are there, like lots of factors here go into this. And then you have boarding sometimes, and exit blocks or access blocks. Yeah. I like this model from St. Emlens though, because it has a specific extra thing with it. So they talk about crowding as cardiac output. So cardiac output is stroke volume times heart rate, and stroke volume consists of preload, Frank Sterling, right? Contractility and inotropy, and then afterload, how much is there. And then you can kind of understand, like, if there's high preload, but there's good contractility and good afterload, then it's all right. If there's high preload but no contractility, then you quite quickly get a stasis, right? I like these like rules of thumbs when I go into the emergency department to assess like what kind of night shift am I going to have. I usually say like there's preload, there's input, throughput, and output. And if two of those three are in a bad way, then I'm going to have a bad shift, right? But if I can choose one, and I usually say this, if I can choose one of them to be good, I want the contractility to be good. I'm not talking physiology here. I'm talking from my experience in the emergency department. Because if I have good staff that I can work with, then even though people would be boarding, I'll just admit them in the emergency department. I mean, it's not the best, but I can manage that. And also, if it's a preload, if the flow is high, well, I can only see so many patients. Like I can't work harder just because the flow is higher. I do have gears, but at some point it's not working, right? I can only see so many patients, and different doctors can see different amount of patients with like different quality as well sometimes. But some are amazing at seeing quickly and with high quality. But it depends, right? So. And this is coming back to the patient power thing. But in my mind, we pick the ones who are sick. That is the thing. Our prior one is the sick patients, right? So we'll pick out the ones who are sick, and the ones who aren't, they'll sadly have to wait. Sadly, they were they're the victims of the system, right? And we have to think about the under triage, of course. The neuro patients and the geriatric patients might have to be triaged up, and the psych patients sometimes as well, right? But the green patients, young patients with a sore throat, have to wait all night. You can take blood samples on them and run the list. We'll talk about that later, how to like manage this. So I like this for its simplicity. And what I especially like is this is only the stroke volume, which is in all the other models, right? But there's this added thing, heart rate. Meaning that with a low stroke volume, meaning that if you have crowding or you have like a bad situation in the emergency department, you can compensate with heart rate. You can compensate with working a little bit faster. You can compensate with training, with wellness and all. If you have a strong and well rested working environment, then yes, you can compensate for that for a while. But if you keep having a heart rate to compensate for your bad stroke volume, you will fail at some point, right? You can't go in 140 all the time, right? Even like so I like this because it builds in this kind of, yes, we can compensate for this, but not all the time. And that's what we're doing. We're building toward this kind of criticality all the time, becoming a new norm. That's not right. So my model is like this. You have these hearts up here and input, throughput, output, right? And then see how many hearts you have left after a while. It's like Mario, where you lose a heart after maybe a few shifts like that. And then, yeah. Okay. Tips for flow as emergency physicians. Different articles for this. There's this legendary one by Campbell where he sent out a lot of articles, or he sent out a request for all Canadian emergency physicians to come with advice for this, strategies for managing a busy emergency department. And he made it into a paper. Read that if you never have read that. There's some pearls in there. The Stimulus podcast, again, mindset playlist. He has a lot of advice for how to survive this as an individual. Again, Ruben Strayer's Emergency Medicine Thinking and his EM Cases podcast talks about this as well. What is to follow now is highly local advice, right? And it's highly subjective advice because I'm no king at this. I'm also learning these things. But I've worked in several emergency departments, and I would say lots of these advice translates to to other emergency situations and departments as well. So, but take it with a grain of salt and see what you can come up with yourself as well. Organization of your ED. Okay, so just historically, before we had emergency medicine in Denmark, at least, it was what you call silo medicine or stuprørs medicine, where you have if someone, and that's usually a nurse in the emergency department, would say like, oh, this is a surgical patient, then the surgeon would come down. If this is a medical patient, then it would be a medicine doctor and sometimes a niche medicine doctor, like a pulmonary specialist, who would come down to see the one who was coughing and so on. And that didn't, I mean, one of the issues there is that you don't have like you don't have a good differential, like this patient, like if it's not the stomach, then they'll just say, oh, it's not the stomach, and then they will have to call someone else, and who will decide who to call them? Well, the nurse has to just call the next one, and oh, maybe it's the heart. Oh, it wasn't the heart. So someone here is making a decision about things that, and maybe after all these doctors have seen and said no, then you're still with a patient who has a problem in an emergency department, and they don't really feel the need to send them home. Like, they don't work in the emergency department. It's often a problem for them to go down and see these patients, right? So that model, I think one of our PhDs in called Müller something, I can't remember his name, but one of our PhDs in Denmark made a study about this, where I think it said that the mortality was higher. Even they could show that the mortality was higher. But even though if it wasn't, then it's usually a bad patient experience where you have several doctors coming down and saying no to you, and maybe these, especially in the hospital or system where these like hospital specialists are becoming more and more niche, then you won't have any, like, they won't know anything about the other specialties. So if there's something on the borderline area, right, then they won't be able to know what they don't know. They will only know their own specialties. So they won't know enough to say, oh, maybe this patient should have an ECG, or maybe this patient should have whatever, right? So so that's a problem, right? And just the fact that they didn't want to be there as well. Oftentimes we want to be there. That's one of the main things, right? Then we can discuss what kind of models we should be using, but we want to be there. We want to be experts at figuring out which part of the body is which here. We will always have to be humble, because there are niche specialists within the field of whatever that knows more about the specific question than we do, but we don't know whether that's relevant yet. We have to differentiate these patients, and that's what our one of our main purposes are, and what our main things that we bring to the table here, our expertise in acute diagnostics. That is not an expertise that others have. Many have worked in the emergency department and say, oh, I can do this, but they don't have the expertise. When you like dissect their thinking, they don't think like emergency physicians. They don't think like what we just went through in part 1 and part 2. And is that how you should think? I think so, and most emergency physicians think so. Maybe we're just an echo chamber, but I think that I think that they are often they are kind of in a Dunning-Kruger kind of situation where they survived the emergency department for 6 months or a year where they have to work there. So and they didn't make any mistakes. Well, what they knew of, right? And maybe they've made one, but everyone does, and that is true. But as we talked about, you can go through your entire career without examining a child for petechiae. Maybe you have to be there for 2 years or 3 years to actually see one of these patients. But if you kept up that strategy, you would be counting much more misses than someone who did not, right? But it takes time, because many of the things that we see are rare. Many of the dangerous conditions are rare. That's the entire thing, right? And then we can have a discussion about whether we are ordering too many things, but I don't think that's on us, that we order too much. It's about flow. It's about our requirements in emergency departments. So it's less about us, I think, and our expertise, and more about the system that we're working in and that we were given, and we don't usually have control over, sadly. So we have to own our own emergency departments and get feedback about it, and then see if we can change things and not be so tribal about it, but try to work together and see each other's strengths in this. But it also means that people need to see our strengths and don't be too like it's. Yeah, sorry. We've been through these discussions a lot with other colleagues from other specialties, thinking that we're not worth it, and we should critique ourselves. Well, if we're not worth it, then we should not be there. But if you ask the patients, if you ask the nurses, they know in these hybrid emergency departments where we have both models, they know who they want to talk to when they have a problem, right? They know who they want to, like, who stands up for them and who helps when no one else wants to. Yeah. All right. So I quickly just talked about it. This is also from the same Danish paper that I've been using so far, where you have oversight or overview over the different organization models. You have the virtual, the hybrid, and the independent. The one we just talked about was the this one is the virtual, where which I just showed you, like the old model where you have a doctor from one emergency department comes down to see that one specific kind of patient that is triaged by a nurse, and if it's not their patient, then they say no, but no one takes responsibility of the patient. That's the old system. That's bad. Then you have the two other systems, and emergency departments all over Scandinavia work in some, like in one or the other. I currently work in a hybrid model where you have an emergency department somewhat staffed by emergency physicians, but we are not enough to take over the entire part. Or maybe there might be some benefit for having some consultants down to see some of the patients where we work together. And different systems organize themselves differently. In our department, there are certain roles that we have and certain roles that the specialists can have, but usually we have the main roles, and the other roles have consultant roles. They might have part of the flow during daytime so that neuro patients are seen by a neurospecialist and a neurologist, but we select the patients to them. We might have a cardiology part, we might have an orthopedic part, so on. And then the other part is where the emergency physicians have the entire hospital. That's in Söder in Stockholm. That's the only hospital, or maybe Södertälje as well. That's the only hospitals in Stockholm, at least, that I know. Norrtälje maybe as well, that have these in the middle of the city. St. Göran, Danderyd, NQS. They don't really have that exact model. NQS is a bit special, right? But Huddinge maybe. More and more are getting. We are getting more and more emergency physicians, so more and more hospitals are going into this model. But I'm not saying one is better than the other. It's like emergency physicians, like they're, especially when it's really clear that you can triage a patient. Like there's not too many other differential specialities. Like there's like eye doctors. They usually have their own hospital because eyes are usually a specific thing. So you can that's a like ideal and like branch specialty where you can select that patient group and then get them out of the emergency department, kind of. But the problem is once a patient has multi problems, right? You have something and an eye problem, like you have a trauma and an eye problem. That's why we have to use that's why we have to do canthelysis. So and in the same way, like like orthopedics is a place where it's really hard to take over for emergency physicians because low risk patients but high amount of stress, a lot of jobs that are not sickness from jobs, needs a lot of anatomical knowledge that we don't usually have if we don't work in it every day. So orthopedics is also an area which is hard to traditionally to take over by emergency physicians, at least in Sweden, with a lot of complaints when they have done. But many departments have made that transition and done it well. But it's not like I'm on the fence on which one of these is the best, especially when you have some niche specialties where we could we could separate the burden, like we could share the burden. All right. So flow through your ED. Yeah. So this is also from that paper. Usually it's in Denmark it's like pre-hospitality or some kind of primary care physician or a vagtlækare who will see the patient, and then they'll do some kind of triage, and then they will talk with the emergency department, and then they will accept or not these patients. That's not how it works in Sweden and most of the world. But it works really well when this part of the system talks with this part of the system, because we are experts in these things and we might be able to steer around patients. So it is a good thing. They've done that in Söder as well here in Stockholm with good results, primary results at least. And then you triage them, and then and so on. Okay, so this is my emergency department. So you have patients in the waiting room. You have actually several different waiting rooms: orthopedic, surgical, and medicine. But they're in some kind of waiting room. Then you have a separate flow with ambulances coming in, either directly to the resource base or to the register. In Stockholm, in Sweden, you have a first kind of desk often where you have to pay. There's a simple kind of amount of money that you have to pay to go to the doctor. If you're really sick, you come in anyway, but you have to pay like 250 or kind of 500 crowns or something like that. And there's a max amount after a while that you can't pay more than 2,000 over a year. Like there's something like that. There's a max amount, but there's a symbolic amount. I don't think it's helped anyone that there is this. But they will kind of sort the patients to either, is this mainly medical or is this mainly surgical, orthopedic, right? And oftentimes that can be kind of hard. Like, for instance, male urinary tract infections, that's surgical in our department because of urology, and female, that is medicine. So there are some arbitrary like things here that might have some kind of quasi logic, but in general, for us emergency medicine people, we just don't really want to have these discussions. Actually, for us, everything is the same flow kind of. We have to take care of everyone. But because we live in a hybrid system, we need to have someone like if a medical patient, like if a medical doctor sees one of the surgical doctors, we are quite broad actually. They're quite good, but oftentimes they don't dislike doing that. They rather want us to do it. So everyone with a head injury, no matter how sick they are, will often get to the surgery part. That's why it's often also a frail place to be. All right, but once they've been selected either to the medical triage or the surgical kind of triage, then during daytime you have a couple of doctors here, doctor here, and doctor here, and then nurse and some nurses' assistants. The amount of these different depending on the time of day. They will then triage the patient, see the patient for 5 minutes, take their vital counts and so on, and take blood samples if needed, or maybe a CT sometimes if needed, and then triage them to either red, orange, green, or yellow or green, and then people will pick them up from here. If they're red, then they will go to the resource bay. If they're orange, then they will be dealt out right away. If they're yellow or green, they'll be in a big pile here. And usually on a day you'll have maybe, it's a normal day where there's like 10, 20, 30, 40 patients waiting in triage to be picked up by, depending on the time of day, 3 to 9 teams consisting of one doctor and one or 0 nurse / nurses assistants. Sometimes we put some of the teams together, but I really like this model of working together with a nurse instead of having nurses that you have to catch and work separately with. I've worked in those systems as well. I kind of dislike those. I really like this model, and I think if you haven't tried this model, it's such a great teamwork kind of thing. And in our department, we're supposed to have at least 3 to 4 patients going at the same time on our team, meaning that you really have to steer flow and steer, like you have to be good at all the things that we talked about. The experience of these doctors depends. Like lots of them are emergency physicians, residents. Lots of them are primary care randare, or like they're having some kind of focused thing in the emergency department for a few months, so they're variably experienced with emergency medicine, I'd say. Yeah, and some of them are internal medicine or geriatric medicine people. Yeah, and it's not as much what's on your sign or what's on your logo, right? It's not your. It's really what you can do. And some of the geriatrics are amazing. Some of the primary cares are amazing, and so it depends, right? It depends. But as a group, sometimes like the best ones are, in my opinion, biased opinion, the emergency physicians, because they can do everything. All right. All right. So you have your resource base, and these are you have 5 of those, and so oftentimes they're all full at the same time. But then you have your surgical flow, and down here you don't have any doctors here, but I'm usually here as one of the leading doctors here, and then I'll be both taking patients, depending on the time of day. I'll be taking patients and being triaged and being the consultant doctors with all of these. So we have it's frail here. It's about to change, hopefully, but it is really frail here as we have a high flow, and there are lots of more resources here. All right, so in orthopedics, same kind of build up as we have in here in surgery, but because many what you call närakuter in Stockholm are taking a lot of the orthopedics, we don't have such a high flow in orthopedics outside of winters or outside of special kind of seasonal days. You can have a high flow, but it's really like seasonal. And then after these, you'll try after no matter where you go, like you'll usually have some kind of emergency physician specialist here. Who can be a question doctor, or if you have a question, you ask these. But we're kind of trying to change that now as well. Here we'll be the surgical asking doctors, right? And then we'll admit the patients somewhere, and we can in Stockholm we can admit either at our own hospital. I'll go back to that in the next slide. But we can also do a fast or slowed outpatient clinic, meaning that sometimes you have times for tomorrow for certain surgical patients, but not for medical patients, for instance, or neurological patients. So you have to admit those often. Primary care usually takes depends on the primary care, but it's so variable, so you cannot depend on it. It's not their fault, but they're just under-resourced. So it can take up to 4, 5, 6 weeks for them to see someone, right? And it's hard to it's really hard to rely on this system, sadly, here in Stockholm. Again, none of their fault. Then you can send them to other hospitals only if they are from other hospitals and so on. And you can send them to geriatric hospitals with doctors in them. And that's usually a doctor's job to send them there. It's not a nurse's job as it is in Denmark. All right. So that's kind of our emergency department, how it's built up. And then there's different staffing. Like during nighttime, there's no here. There's 3 here. And there's 2 here and 1 here. So, yeah. Disposition. All right. Or selling patients. So we'll talk about Peter Nugent's and Jeffrey Braithwaite's article called "Selling Patients." Disposition is how do you get the patient away from the emergency department, right? Either home to outpatient clinics follow up, or in like admit them or so on, right? But you will get the notion that sometimes it's like selling Pokemon cards to a nurse when you're trying to admit them. That's the notion of selling patients that they're trying to get at. We'll talk about that. Okay, so usually what I try to describe in every hospital I get to, I want to like have what is the tier list of our hospital? What are the highest and lowest? And in Denmark, when you work there, it's just you don't have much of a tier list, right? You don't have what you call step up and step down in the same way that you have in United States or North America or England or Sweden. You just have intensive care departments, And then some departments can do some things and others can't. But you don't have to step up and you don't have to step down. So I'll usually the patient, instead of like saying, oh, this patient needs admission to medicine, it depends on, like, patients are so complex now that they have multifactorial problems, right? So when we are thinking about disposition, we need to know, like, what are their needs. Do they need telemetry? Do they need isolation? Do they need higher, like, what can they do in the higher care situations? Usually they can do some airway stuff if they need to be intubated. They can do vasopressors. They can, but the most important thing is that they have 2 nurses usually looking at them at all time. They have a high observation level, right? So, and that's not my words. That's a critical care author called Matt Morgan, who's made the book Critical, which is one of the books I haven't shown you. But yeah, they will show you kind of like, yeah, what is important. And that is, he says that the most important thing is that you have 2 nurses as opposed to 1 nurse for, I don't know, 7, 14, 28 patients, right? So think about that when you also are newsing your patients or saying how often they have to look at them. Like 3 times a day, then you don't have to wake up at night. 4 times a day and above, then you have to wake the patient up at night. And do you really want that? Usually don't. Okay. In our example, our hospital example, you have the ICU, which is the highest level of care. You have the EMA, which is intermediate medical. And some hospitals in Sweden, you'll have a surgical EMA, which is like 1 step down from ICU. And then I placed these, the heart intensive care and the neuro intermediate care. Here you do have, like in Karolinska, you have neuro intensive care, you have thoracic intensive care, but that's not this. That's not these. These are like a part of the department in the cardiac and neurological ward that is for worse off patients. But they can. The reason why I put this higher is because they can take all kinds of patients. Maybe with the exception of surgical patients, because it usually depends on local stuff, right? Surgical patients are usually getting up here, but these can see only cardiac patients. These can see only neuro patients, with some exceptions. But in general, they have to be quite quote unquote clean patients. This is what I would call higher level care. There's usually more like the ratio of nurse to patient is quite high in these, like 1-to-1 or 1 or 2-to-1 or something like that. Then you have, I wouldn't call it lower level care, but you have normal care. And then I would say, like, how do I triage these? Like, how would I tier these? Well, the ones that had telemetry and isolation spots, those are the best, right? Especially if they're staffed with people who are good or flexible, right? And then you have some departments who have NHF, like non-invasive breathing, or high flow nasal cannula, or NIV. Then you have some that have telemetry or just isolation, or you have some that are mixed departments, right? And mixed departments are gold, and we'll talk about why. Because sometimes most patients, when they leave the emergency department, don't have a definitive diagnosis, right? They don't have a definitive specialty that they belong to. We need broad departments that both can take care of surgery and medical and pain and psych and everything, right? But we don't have that. But that's the emergency department. And if we have a 4-hour rule and we have to get patients up, then it takes a long time to figure out which department they should be admitted to. And I do agree, though, that sometimes, like, some emergency departments work like you can just throw them up right away, and then you have a lot of patients that are surgical that live in the cardiac departments. That's also a problem. So there's a Goldilocks amount of time where you have to keep the patient in the emergency department and think about where do they end up best. I'll give you an example, right? So when you have for instance, surgical patient, sometimes you have a young surgical patient where it could be an appendicitis, but it could also be a gastroenteritis, and it could also be IBD, right? So it could be a medical thing, it could be a surgical thing, but they are hurting in the right lower quadrant, but it might be a bit of an atypical presentation. So there you could order a CT and then wait for the patient to actually get the CT to get the diagnosis, right? Because you have either they will be admitted to surgery if it's an appendicitis, or they would be admitted to IBD care in the gastro internal medicine, or or they might need isolation or whatever. So sometimes this, or they could be even get follow-up care by the primary care physician, right? So after that kind of patient, I would usually let them stay in the emergency department. Unless there's lots of spaces, then I'll admit them, but usually there aren't. So there's some tactics to this, right? Especially during the night shifts. You don't want to waste your only beds in the house on patients like that. Nothing to do with the specific patient, but like you need those spots for difficult patients to handle in the emergency department, like delirious patients or so on, or patients that really need surgery, right? Or need something specific that only the department can do. So there's a tactic there. But this kind of like talk about specialties get easier when the patient is sicker, right? If you have a really sick patient, or usually it does, because if you have a really sick patient, then you'll just admit them to ICU or IMA, right? As long as it's like ICU, they take everyone, right? But if they're just below ICU, then it's usually a problem if it's a surgical patient. So in my department, so there's these. I'm sure like these are very highly local things, but I'm sure you can kind of you could probably know it from your own local hospital, these kind of strange routines, or like in every hospital I've been to, it's like this, right? Okay. What I wanted to talk with you about is this, what you call it, what we could call, one of my colleagues called, and I've used it ever since, a avocado patient. So emergency physicians in the emergency department seeing mixed patients, right, from mixed specialties. We don't think about it like specialties, right, but we think of it as problems. But others would still see it as specialties, because we have to some extent to see it like specialties, because it's like because they have to be put in these into these boxes that have a specialty number on it, right? So we have to like somehow have that kind of mind frame still, right? To see like, oh, this is a surgical problem, this is a medicine problem, and so on. Avocado patients are patients that belong to several specialties at once, and you've tried to call several specialties already, and the more you like the avocado in the supermarket, every time someone touches it, every time you try to call someone and they say no, it becomes worse. It becomes harder and harder to sell, right? These patients, they can also be called stones. That's what they call them in House of God. And again, it's nothing to do with the patient. It's just a descriptive term to say that if you have an avocado patient, it will take you sometimes the entire day to get them in. And oftentimes, sometimes you do. This is where this like selling patients comes into the picture, right? So on a day where there's hard access block, you'll never get these patients in. Sadly, they're really hard to get in. It's like one of the main problems is if they have no discernible pathology, right? They want to get in, there's no discernible pathology, but they have a really, really like they're chronic patients and they're pain patients and so on. They can't live at home. Like these patients are a nightmare to admit. No one wants them usually because they don't belong to any specialty. Pain, right? So what can you do? What is my advice? Well, fly ahead of the plane. So if you know, like with experience, you know quite fast that these patients, you have one of these patients on your patient list. Flag them so that you know like this is a problem, and in some systems you can like to get rid of the 4-hour rule thinking. You can just say like this patient is already admitted, but there's no bed like, and then quickly like if more than one or two departments says no to it, then quickly escalate it and discuss it with a colleague how to do this, because oftentimes, especially for you who are residents, because these patients are hard to place and they can stay in the emergency department forever if we don't have a plan for them quickly. And these are usually the patients that's because of crowding, or like suffers a lot in crowding situations because they're impossible to admit. Outside of the chronic pain patients, you have maybe like one of the classical examples is the hip fracture, where where they also have fallen for a reason. Maybe they have a need of telemetry because it was dysarrhythmia. Maybe they've hit their head, so they need a CT scan as well, and they might need sutures. And like this, like quote unquote, an emergency medicine kind of patient where you need all specialties in one doctor, right? That's efficient, but it's just when you're living in the hybrid model, it's really oftentimes hard to get these patients in. Okay, so fly ahead of the plane. So as we talked about in all the other parts, it's a really important concept. Be kind. Everyone is doing what they can. When you call the nurse, we in our hospital have to call the nurses to admit them and do the report. And it's like when you call the nurse, be polite. Know that they are doing their very best as well. Don't be rude. And of course, you should advocate for your patient, but you also have to talk with that nurse another time. You are their colleague, and if you work at the same hospital at the same like more than just a month, you will often meet the same people, and they will oftentimes remember you, especially if you, like me, have an accent. They will know you, right? So I think we should try to help each other out. And like oftentimes, oh, we can see this patient, but in a maybe in an hour. I was like, okay, sure, I can keep him down here for an hour. Like that's no problem as long as I have a spot. Okay, that's all right. And I'll just, as long as my statistics is not going on it, like I can just pause the 4 hour rule for those. If you can't do that, then then you might have other local suggestions to make to your chief, right? But don't be bothered by these. Everyone is doing what they can. If there is a system problem, then it's something that you document and write to your whatever, like in your system, so that you can take it up on a higher level and see like, is this really how we should work? But don't be rude and avoid tribalism, right? But advocate for your patients, as we said. So you have to know, like, okay, so for instance, when we are boarding, and we board every night almost, then we have a special list where you can list like which departments take which patients in which order. And oftentimes, I'm not saying that the night personnel sometimes try to sneak their way out of it, but they're low staffed and they don't necessarily want another patient, right? And so sometimes you just have to have the document in front of you and like say, well, there's this document that says that you have this. Do you have this spot? Then I have to give you this patient. And sometimes you can oftentimes, like if it's early in the night and you know a lot of patients is coming in, there's already 40 waiting, then you know, like, I might as well give this patient to your specialty because this is a patient that belongs to your specialty. I know you just received 2, but then you're full, right? And then you don't have to take any more patients. So that's the thing about selling patients. That's like, be nice, be polite, but also and the thing that Peter Newkes talked about in selling patients is that you kind of play up some things from your patient, like Pokemon cards. Like you say, like, oh, he's just a little bit psychotic, not much, but and then you like kind of hide that for the end. You'll play up that this patient is a hematological patient. It needs your specific hematology department and your expertise. And I will, yeah, of course, I already I've already done all the medical, and I did the no CPR thing because or I did like do a decision on that, and I did do all the like. There's a lot of bargaining here and treatment, like that's what and it can, I don't think it can be any different. That's what Peter Newkes talks about, and try to, like, in Life in the Fastland, he has a video on this, so it's great fun to see this and just like kind of just see that admitting patients is beyond just what kind of condition they have, unless they belong to them, like unless it's obvious. But most patients, it's some kind of trade-off down here, and sometimes you have to. I'm against it, but sometimes you do have like these avocado patients. A cheat to get them in is to like, oh, they need isolation, or oh, they need telemetry. Then they can only be in these departments. But yeah, I know it's not. But you need to get the flow going. You need the best for the patient, right? So again, tribalism. Check out Vic Brassel's talk on medical tribalism from SMAC. And in general, it's like this, right? So we want to be up here on the highest level, kind of. where you many of us are on 4, right? Tribal pride, like people are fully themselves and everyone seems happy, inspired, and genuine. The culture emphasizes shared core values and independent, but it's still like we're great. It's not like life is great. It's not language. Like oftentimes we stop at stage 4 where we like try to we think our group is the best, but the others are not. And oftentimes we it might be against human like tribal behavior, but trying to get up here, trying to say like we are all great, we all want to try, and we have some things that we can do, and you have things that you can do, and we have to cooperate, right? Yeah. You can check out this. This is from Big Brussels as well. All right. Before moving on, I just wanted to show you this from Grant Innes, also one of those who talked about crowding. He's made this article long time ago. I think it's like early 2000s about patient PWDP, patients without discernible pathology, and how to when we talk about these avocado patients as well, like what to do with these patients, right? So the criteria are patients have no definable illness or pathology. Patients or family members believes hospitalization is essential. Consulting physician believes discharge is essential. We've all been here. We are probably here every shift, right? Patients who want to be admitted, but you don't really think there's a reason for it. Depends on what your crowding situation is and your admission criteria are, and like depending on the patient, like some of these soft criteria. Does this patient ever come to the emergency department or not? If they're a frequent flyer in the emergency in the emergency system, and that might be a soft sign for like it's probably not that, like it's more anxiety induced and so on. But sometimes like you have to be careful, right? But we all kind of we can laugh at this because we kind of know these patients. So does the patient meet the criteria? Well, if yes, then can patient ambulate independently? Yes. If no, then you can just attempt admission, right? Because if they can't walk, then you can try. Is the family member to nursing staff ratio less than 1? Well, no. Well, then you can try admission as well. And each suitcase is 1 family member, all right? Then you have is H plus BUN, which is like creatinine and carbamide or something and like that. It's like is H plus less than 100? Well, no, then you can attempt admission. If yes, is inpatient consultant a reasonable and compassionate human being? If not, then attempt admission. But if yes, then you can try to discharge, because they know that this patient should not be in. All right. So yeah, it's just like admission is hard, right? I recommend you trying to look into this paper and selling patients by Peter Nugent. Tips and tricks on your shift. Okay, if you're a frontline doctor like I was not too long ago, I still am in some roles, but now I'm a specialist. I have other roles as well. I will give you these advice, right? So before any shift, know the part 1 and part 2 and part 3 that we just talked about here in this lecture, like probabilistic thinking, illness scripts. I'm not saying you should know everything, but you should know some basic things, right? The most common things, or at least how to look it up. You need to know where the books are, and you kind of have to have went through some of the books. You need to have a strategy or logistics, right, before going into the shift. And then there's lots of things you don't know that you don't know, and then you have to know who to ask, right? If you get into this problem, who do I ask? If you get into this problem, who do I ask, right? That's kind of how you plan for the shifts. No standard treatments, yeah. And that's, yeah, at your hospital. Takes a while, but you can learn it. References, where to find answers, as we talked about. And sleep, eat, work out, and the sex and so on. All those wellness things, important, especially before night shifts. Have a work wife or a case reviewer, someone who you can rely on and talk to if someone goes south and you want to, after the shift, talk with someone. No complexity. You can only do lots of reasons to know complexity, but in general, you should know that you can only, if there's a high flow, you can only do so much. You can only see so many patients per hour. Okay. So it's like that, like the second in this block about game theory. This is all about this. Like we play a infinite game, right? There will be infinite amount of patients, infinite amount of days, right? It's not a finite game. And because it's not a finite game, we will not be able to we might be skilled or good, and then we try to like empty the emergency department, and then the next day it will be double as hard, right? We have to be able to survive in this as well, and we need to know our priorities, both home and at the job, and that is sick patients, right? And then of course compassionate care and keeping up the flow and so on. That's priority 2, right? Compassionate care education as well, and all like deliberate goal. Yeah, you have set your you have your growth mindset. You know kind of your plan to how to like through your residency to kind of grow, right? You have your growth mindset. You have your you plan out your illness scripts, your procedures, all of these things. I know it's hard, right? But you kind of know where you have to go, right? And during your shifts, once you come in, especially during nighttime, run the list. I love to come in maybe 20, 30 minutes before, maybe even more sometimes, if I know it's a really hard shift. Come in, run the list, and see, like, check out in our list, you can like make small comments. So I can like say, blood samples normal, blood samples normal, blood samples normal. Oh, troponin 800. Okay, I'll pick that patient right away. Like, so you can like kind of flag patients that might have been under triaged to whether you should pluck them first or not, right? And in many of the emergency departments, it's like, oh, you should take from the pile and take the one on the top. Yes, to some extent. Like, as an emergency physician, I believe that my priority is to see the sickest patients, right? Or at least to find out who, like, of the entire flow, who is sick, who needs care right now, and even like there's a balance there. If the sickest patient is not that sick and has only waited 30 minutes, and the other one who's green, who's waited maybe 16 hours, then of course you take the green one, right? But it really, like, you always, it's a smart. You can make it hard and you can make it easy, right? And if you just make it easy, you just pick from the pile. But once you gain responsibility and experience, then you know that's sometimes the right decision and sometimes the wrong decision, right? Also, you need case mix, right? You can't take 3 PWDP patients, as we just saw in the algorithm, right? You can't take 3 of those patients at the same time. You will be there forever, because as I found out in psychiatry when I worked there, like, you are the test. When you're communicating with the patient in psychiatry, you are the test. And the same way, when you have someone you need to talk with, you are the test. You are there. But the reason why we can see many patients in medicine, in emergency medicine, is partly because we can order tests. We're waiting for tests. So we have many balls in the air at the same time, right? So you have CT scans, you're waiting for those. So you just pick the patients that way where you can maybe also, as part of running your list. If it's a short list, you can, or if you have time, you can go out, triage the patients that obviously need a CT scan. Oftentimes they come in because they have from the admission for the note from the primary care physician, you can see, oh, this patient needs a CT scan. Then you can just order it, and well, you should see the patients before, but I have from time to time when it's really, really busy not seeing the patient if it's really obvious, but it's much better to see the patient first. So see the patient first and then order the CT scan, because that's these are things that makes flow happen, right? As long as your decisions are solid, and then sometimes that could also be a factor. If you have to see a lot of patients quickly, then sometimes you do make less solid decisions, and especially I think radiologists would agree with me there. And sometimes you do order a little bit more than you should. And then the flow for the radiologist is a problem. So it's a give and take, that thing. But in general, run the list, see who you can pick out and who you can order a CT scan on, who needs it anyway. And when you are ordering CT scans, then order them so that you fly ahead of the plane, right? Do they need a CT scan of the head? Well, go in there, check all of their limbs, all of their back and everything, to make sure that they don't need anything else, right? Don't just blindly order a CT scan of the head just because they hit their head. You need to see the patient there, right? And all of these, like, what kind of CT scan do you need? Like why did they fall? Why do they fall? Do you need maybe a contrast CT scan of someone who has a belly pain? You need arteriography so that they don't have to go there twice, right? So you need to think ahead of the plane what kind of differential diagnosis. So already in triage, you really need to think about these things when you're triaging, and that's a lot to think about for a frontline doctor, right? But these are the things that when you triage and doing it effectively, then you should do that. During the shift, compassionate care, of course. I'm sorry that you have to wait for 18 hours here. I'm sorry I'm seeing you. Can I give you anything before we start? And that's why also partly it takes a while during the nighttime, because you have to say sorry all the time when you have these shifts where everyone is, and you might like you could go through them, but that's not the compassionate way of doing it. And of course, if they're really sick, then you do what you do. But if they're not really sick, then you like kind of do it as a human. Fly ahead of the plane, as we talked about, and make a plan so that when you're sitting at your desk, you know, like when you walk away from the patient's bedside, and then close that sack, like close it, so that you've seen the patient, you've sewn the patient right away, you order the CT scan, maybe you order the CT scan so that you sew them, or you order the CT scan first and then you sew them, so suture them, so that meanwhile, while the when the CT scan crew then comes, then great, then you just suture them, finish, right? And then you just finish suturing them. Then you go do their medication list, or you write out their medication or print out their medication list, and then you give it to them so that whilst they're away, they can you give them a pen, then they can see their medication list and cross out which ones they don't use anymore. Then you get the list, and then you can come back, and then especially if you have long lists and there's elderly patients and you don't know what medication they take, but they do, or usually when they see it on paper, it's much easier for them. So write out that print out that medication list, and then let them fill it out with them. And then once you get back to your computer, then dictate aggressively, right? Aggressively dictate the patient so that you don't have too much waiting. Like sometimes some shifts are just chaotic and you can't try, it's hard, but I would never not dictate on anyone. Like I would not have 2 or 3, max 4 maybe dictations waiting. Then I'll just stop. I need to dictate because otherwise I will not remember the plans. And have a small notebook where you can make these notes what to do. So you have a plan, or you remember tasks that you have to do. Don't make it too complicated. Don't write too much, but just so you know, so you have a memory aid. Because sometimes, what you call task switching happens often in the emergency department. You should avoid task switching as much as possible. That's why you also should try to close the bag once you have seen one patient, and just do everything you can and have a plan with that. Like fly ahead of the plane. What if the test is negative? What do I do then? Am I ready to send them home? No, okay, then I have to admit them. Close that bag as much as you can before moving on to the next patient, right? Okay, close the sack, right? Okay. And because then you have a plan also if it gets to the morning and you have 8 patients on your list and no one has been admitted, but then you can move them over to you can hand them over, my plan is this, if this, then this, if not, then that, right? Then you have a plan and you've already made that plan. You don't have to make the plan while you're doing the handover. That's horrible usually, even though happens, but it's much easier to do it like this. You'll be much less cognitively loaded. And you can move on much easier during the night shift. Yeah, minimize task shifting as well. We talked about that. Be done with what you're doing, especially medication lists, or things that take a lot of mind space to do. Please just do it, and they can wait. These Gs can wait to be signed. Communicate with your team and team huddle. Yeah. If this happens tonight, what do we do? What do you want to oftentimes when you work, or when we work with one more junior doctor than myself, and oftentimes they don't. Sometimes they can do a lot and they can do everything. But I just want to do a psychological safety thing. You can just ask me anything. Don't worry. Here's my number, and also give the triage nurse, here's my number, if you need anything. Right? I've done that all through my residency as well. So that we can communicate with each other, and there's a safety like you can do, like the psychological safety is so important. It's not just on the like resource teams. It's also in these kind of teams with your nurse, with your night shift personnel. And what can they do? What can't they do? Right? If there any situation that you think is arising, or with your right, like can they suture? Can they take? Have they been in the emergency department before? You're a junior doctor and all, so you kind of expect manage expectations throughout the night, right? See roughly one patient an hour. Yeah, that's what they say at our place. I can get around that number almost, depending on the case mix. Sometimes it's more, sometimes it's less, but around that is probably reasonable. Be a role model, as we talked about before. When consulting, use the S bar. So when you are asking someone, or someone is asking you, sit down and write on paper, so that you know what they are saying. Especially when someone is consulting you, I will advise everyone to like write S bar or Mabel's OBQRST. That is what Eric Driver is doing. I think that's too detailed. I usually just write S bar. But the reason why Eric Driver writes OBQRST is because he wants to get all the details, and if you're missing some details, then you'll get that way. And then you can show the one who is consulting you also as a teaching thing, like you can see what you're missing. Yeah, but we'll get to that when we get to the consulting tips. But do an S bar, and I'm doing the S as a James Bond S. So don't, like, this patient like, I haven't shown you the Judith Bowen article, but Judith Bowen has a great article about how to do the S bar and how you can see an S bar from an expert versus a novice. Educational strategies, I think it's called, something like that. I'll show you later. But it's like one of these legendary articles, and it talks about these. Like S could be like just belly pain, but it could also be like these qualifiers that you can add to them, like sudden belly pain in the right quadrant. That's also an S situation, right? It could also be if you're already like concerned with this patient, like patient coming in with shock and belly pain, I think it's an aortic aneurysm. Then your consultant will hear right away, right? Because otherwise they'll just say, I'm too busy. Can you call in 10 minutes? And like, wait, I have to tell you this. Like, okay, it's like belly pain, aortic dissection, and then you can like hear the constant like. Oh, it's a story from Eric Driver. He tells it better. But the general thing is your S has to be a James Bond S. You have to put as much information that is relevant into that, right? Your S bar tells something about what kind of differentials you've thought about, right? So when you're doing the S bar, you have to do it skills. So the I is identification, like, or we usually in Denmark say ISBAR, ISBRA, BAR. So the I is identify yourself, and have you called the right person, and is it the right patient as well? And also I usually ask, like, do you have the time, or should I call another time? And also, like, why are you calling? Identify the cause of why you're calling. Like, I'm calling because I need consultation, or I need your advice, or I need, yeah. And then you do the S bar, and the S has to be sexy or James Bond S. Then the BA can do whatever you want, and then the R you have to come up with an R, right? You have to, like, to be able to learn anything from these consultations, you need to come up with an R, because you need to, like, I would think we should do like this. What do you think? Because you haven't thought through what you want to do. If there weren't any consultant there, then you wouldn't know then you don't learn anything. It's so important to get to the R, especially as a frontline doctor, right? Especially as a resident. And also during, especially night shifts, but also in general, in the emergency department, you do the minor tasks as well. Do what the nurses have to do, like give the patient food, take out the PVKs or the like the lines. If you're the one, like, if the nurse is the bottleneck, then you do it, right? It's easy, and instead of you having to go to see the nurse and say, like, it's easy to do it after the shift. Really important especially after a night shift, that, like, you need a cold room to sleep in. or a cool room with all the sleep hygiene rules that you can check out in the EM Cases blog and in the book that I just showed you in the part 3. Like, do all of these things. It's really important to get to sleep. Don't drive on your way home. Please get some sleep at the place if you can. And then whether you use goggles with red light or whatever, all these things. I mean, lots of trends, some evidence, but I mean, do what works for you. But sleep does work. Keep up, eat healthy, work out. I often love to work out. And depending on what kind of shifts you're doing, I mean, I like to do shifts 3 in a row or 2 in a row because then you have a lot of time afterwards. But it's not. Try to get sleep, work out, get out, see sunlight when you're awake, and then and then maybe think of one thing that you like want to improve on your shift, or maybe one thing you learned. I usually go to IBCC. Oh, there was one thing, and I don't know with you guys, but I often get negative thoughts, lots of very negative thoughts when I'm after my shifts. When I'm it's just my way, my brain's way, I think, of saying like I'm done, and I try to push those away. I try to reframe or try to just push them away and say it might be time to think about these things, but I'll think about them in the morning when I'm well rested, because oftentimes nothing good will come from it. Okay. If you did have a bad case or not, share with your work team again, shadow box with them and so on, and reflect upon or seek feedback, right? Thanks for the feedback style. So know what feedback is, and like if you work with someone during 3 shifts or so, give them feedback as well, your junior doctors. But yeah, so these are just some of the things like we talked about, and we talked about other things like when you're working at your ward log or with your nurse, like you have 4 patients and you try to block the patients, like, and you go into one patient's room and then order things and go back, and I think we've been through many of the things, lots of other advice, but yeah. So before seeing the patients, print out the medication list as we said. Make a plan for when you see usually make a plan for when to see which patients. Sometimes you have 3 or 4 patients. Some of them might take a long time. Don't see the ones that take a long time first. See the ones that take a short time, and then you can order a CT scan, and then you can go in to see the long ones once the CT scans are waiting, right, or something like that. Yeah, try to have some kind of strategy there. When you see the patients, if you want to like speed up without losing compassionate care, then you bring your ultrasound. Like John Broderson's studies on this has shown that it actually works to make the patient feel heard, and like examine your patients, touch your patients, but also like this, like sit down, let them tell a story, all these things that we talked about. But there is a trick to get them to tell their story a little bit faster, or at least to make. I think this is a power thing. Like it's a really good thing to do. Oftentimes to read the letter from whatever doctor who sent them in, or read their story and see. I can see, like, start your sentence with, I can see that you've been in and done this, and this. You had a rough week for 3 days now, and now you're here again. Is that somewhat right? If they say yes, that is okay. Can you please from there then say, how can I help you? Because if they have to tell the entire story back, that will take a long time. You've just read it, right? So you can summarize what you just read, and then you can go on, right? Eric Driver would before going into the history just do a Maples. I think that works sometimes, but it doesn't, communication wise, especially with long medication lists, it doesn't really work to do the Maples first. I think I usually don't confirm the previous conditions either. Maybe just a few of them, but if they've been in for a long time, I don't. Yeah, and sit down, introduce yourself, exit listenings, validate the patient. Like, I'm sorry you had to wait. Do you need anything before we start, like pain medication, water, food, blankets, and so on? About food, please check out First 10 EM's podcast on Let Them Eat, or blog called Let Them Eat, or video Let Them Eat, because it's really like almost no one has to fast in the emergency department unless they really, really have a truly surgical emergency. Right, most of them can at least drink water right? No problem. You can fast 2 hours, and then most patients will not get into the OR room within 2 hours. So let them eat, or at least let them drink. And expectations management. I set the boundaries. Like what we do here today is this, and do that every time. Like I cannot know what it is. Sometimes I can, but my main purpose is to root out dangerous stuff. Okay, and so I will send you home with pain, as long as it's bearable, and we'll have a plan for that, and so on. And trying to find out why they came in right like today. What is the reason why they came in outside of the presentation, like belly pain or whatever? Why did they come now? Was it the what you call the end of the rope syndrome? Like they can't take it anymore at home? Is it became gradually worse, and now it's too much? Did it become way too much suddenly? Is it because it hasn't gone over, and so on? Or is it because their primary care physician couldn't see them, or they're nervous? Like, try to figure out that. Stimulus podcast has some great advice on this as well. And ask broad questions to begin with. Don't interrupt. Let them tell their story. Pick up the dangerous illness scripts, and then like ask specific afterwards. Like, do you have pain there, or was it like? And try to ask semi broad, so that they don't like, so that they don't walk into a diagnosis, but you can kind of like can ask them a little wider. Like, for instance, for pericarditis, it's like what you want to know is like, do they have pleuritic chest pain, or do they have like pain when they're lying down? And like you cannot just ask, is there, like, first question is there anything that can make this worse? That's a semi-closed question, right? Nothing can make it worse. Okay, and then you can ask specifically after that. Oh, what about lying down? Yeah, maybe in my book, if I have to go so far along this, like the more and more specific questions, and only on the very specific question they ask yes, then it's usually quite a low likely ratio on that, right? Okay, so how to ask is really important. Ask broad questions, yes, and give the story back, as we talked about, so that they know what to do, right? And they understand what you've just done, what you just worked them up with. I often, as I said, print out their blood samples and maybe CT scans, so they can get them with them home. Write a plan: step 1, step 2, step 3. If you have the time, I don't do it with everyone, but I try to. And give them a rough fly ahead of the plane workup plan, a time frame, like when you're working, like, okay, so you kind of know as you get better at this, you kind of know what the workup is. Like, we do this, and then right away, like right off the bat, especially if they're elderly and they're falling, like, if everything looks normal, what do you want? Do you want to go home, or do you want to go to geriatrics? Do you think you can go home? And oftentimes we say, no, I don't think I can come home. Oh, great. Then I'll admit you right away. I know you have to be admitted, then I can always already flag that, right? Okay, tips and tricks as a consult or triage emergency physician. Okay, triage, just quickly, why do we do that? Well, seeing the sickest patients first and utilizing the resources for them. The problem is that we don't have enough resources at any point in emergency medicine, right? And it comes from Napoleon on the battlefield, where his doctor had to triage the ones who could survive and who couldn't, right? So no need seeing the ones who couldn't survive. And I guess our triage is not too much about who survives or not. It could maybe be, but we are more flagging the ones who really are sick, right? There are many systems, Rett and West syndrome from Göteborg, the depth system and the adept system, I think, used in Denmark and so on. Lots of different systems. All of them like have issues. The good ones have a gestalt built in and are aware of over and under triage. North Americans have a different system. Manchester have a different system. Different systems have different systems. But I don't know. I'm not into the evidence of these. But when I've listened to lectures on this, seems like the evidence is not too good for like picking up. But we need some kind of system to pick up the sicker, and none of them are perfect. We have to always think about under triaging, like meaning that the patient should have been triaged red or orange, but they became blue or green or yellow, and which is low triage, right? So many of them are, some of those who are often prone to be under triage is neuro patients. They usually don't have lots of vital parameters that are bad. It might be geriatric patients and frail patients. So a lot of systems now incorporate clinical frailty score that gives them score like that scores them up. Immunodeficiency patients, they should also be triaged up or isolated, and depending on what kind of immunodeficiency they have, but they should also be flagged in some way so that they could be seen a little bit quicker. Homeless and psychiatric patients, I think so as well, because they don't feel great in the emergency department. Most people don't, but they don't have the resources to actually feel great there either. So especially psychiatric patients with psychosis, they should be triaged up. Children, vitals are vital. They have to be all their vitals has to be explained in some way. If they have a abnormal vital, they should. And the main discussion is tachycardia. And I know there are some studies where you can just don't send home patients with just tachycardia and it's okay, but it depends, right? So you need to know what you're doing, and you need to have a good were the vital signs taken while they were crying or not. But you really need to explain every vital sign in a kit. Vitals are vital, and you need to treat them. Pregnancy, you have own use instead of normal use, because such things as blood pressure over 140 is highly pathological in pregnancy as opposed to normal patients, because preeclampsia and so on, right? So, yeah. All right. Okay, triage or clinic leader or consultant. Before the shift, much as the frontline clinician, you need to know all those things that we just talked about. Know the CBRNE or catastrophe plan and the plans for escalation if something, like if your sandcastle collapses, major incidents and so on, right? Then you need to know how do we get resources to this place quickly. Know the cogs in the system, that's the thing, right? Check out who you can call. Like you, I found out as a specialist as well, like just because you're a specialist doesn't mean that you know everything, right? You need to know who to call if something is, if you don't know, right? And sometimes you have friends in the hospital working the same shift, so I often check the shifts, like who's working the shifts, and I know like where do I have my resources. I do the same with the people working on the ground, especially in night shifts where it's more like you don't have too much time to think. You just need to make decisions, right? And try to not, like, this is an advice for Scott Weingart. It's like decision fatigue is a thing, right? So he doesn't want to make too many decisions if he doesn't need to. So if you don't need to make the decision, don't make it. Like make the resident make the decision if it's a low risk decision. Like where should I admit this patient to this telemetry department or this? It doesn't matter. Just do it. Right? You do it because every time you have to make a decision, it grinds on your decision battery kind of. And so yeah, advice from Scott Weingart. You of course have to sleep, and all this sleep, workout, sex, and all of these things is important as with everyone else, like before. If seeing sometimes I have to be the triage and the consulting doctor and also see patients at the same time, while especially when I'm working surgery, emergency department, and then it's like you have to pick patients that are easy for you. Right, and that depends on what kind of patients are easy for you. You have different niche specialties and interests, right? So, but I usually pick neuro patients. Those are somewhat easy for me usually, and I pick other like patients that I can trauma patients that are also usually quite easy for me, because you can do an examination, you can order a CT scan, and you know what you have to do afterwards as well. So these are usually easy. Don't pick too many of these PDWP patients or avocado patients, because some of my colleagues like to do that because they know they'll be involved anyway in these patients, and that is a good argument as well. Like if you have a really junior doctor, you might as well pick the complex patients because you know you'll be involved with those anyway. But oftentimes I feel like for some of these patients, when you really have to be delicate with the communication, then yes, I would like to do that. But for the others that are just complex for other reasons, then usually make them take it, and then you can go in and do pinpoint consultations if you need to. Have a plan if you're alone on the shift. So yeah, if you have to have a plan, if like especially when I'm working medical triage, if something happens like where you have 3 alarms going off at the same time, or 3 really sick patients, probably 1 resus patients coming in at the same time, what do you do when all the competent doctors are gone, to all the, like, you don't have any more competent doctors to pull in? Do you take an incompetent doctor? Sorry, not incompetent doctor, but someone who's not used to taking the resources, and then just make them a scribe, and you do the thing, and then they like you they do the thing. Or do you call down one of your consultants from the hospital, and you just please, can you come down and see this patient because we have 3 others coming in now? Have a plan for that, or yeah. Know who you go-to frontline doctor for difficult cases is, right? So you need to know what, like, again, look at the schedule, see who is your friend on this shift, right? And high five them before the shift, and communicate as well. Like, give them the numbers, give them your phone number, make psychological safety. You can always ask, and so on. Okay. During the triage, fly ahead of the plane, order workups and treatments to facilitate flow, mark patients who you're worried about, and also maybe who needs to be admitted, right? Yeah, one of the common ones is like that you order CT scans on, for instance, is thunderclap headaches presenting within 6 hours, or CT scans needed on PE workup because the D-dimer is only good within 7 days, and if they have symptoms for 8 to 10 days, well, then they need a CT scan, then you just might as well order now. Just be sure that you don't need more CT scans later on. So I would never I would usually wait to order it if there's an X-ray first, and then I wouldn't order if there's a high risk of them needing more. Then I'll just leave it. Use POCUS. I haven't written that, but use POCUS as much as you can, because it's a game changer, I would say. Especially in pleural effusion and all these cases, you can pinpoint a lot of things quickly with POCUS. Also gallstones and all, like, really quickly you can see a lot of things that you need to see. Why is the patient here today? Again, try to manage expectations and try to do compassionate care also in triage. Like, it's much easier to see a patient as a frontline clinician after a good triage doctor has seen them, because they already know, like, they've already told them this is what is going to happen, or this is, like, you have to be here, and it's like it takes a while, and we only will work up dangerous stuff, right? We'll not find out what is the cause. That's not what we do here necessarily. That's not our primary goal, right? We'll try to get you advice to go to the next place, but not, yeah. If low inflow, see patients with if there's really low inflow, then you can sometimes do co-triaging, so that the patient doesn't have to tell the same story several times. It's really good to do it like that. When you're doing consultations, we talked about, like, demand the S-bar, right? There's time for demand the S-bar, and demand that they've done an R in the S-bar, or a good reason why not, if it's a critically ill patient. So usually I would say, like, if there hasn't been any blood samples in yet, if there are no blood samples in yet, and like, I would not like to have more than one consultant from the same doctor on the same patient if I can avoid it. Sometimes it's unavoidable, but in general, I'll try to educate my doctors to not, unless I'm in a teaching position where I have to, like, before you go into this patient, think about these things, and then go into the patient. But if I'm in a production mode, then I would like to only see consultations after all the tests have come, or before, like, they want to order a CT scan, or like a important decision in the kind of chain of decisions, right? Not 6 times before ordering blood samples. And you have to tell them that oftentimes, and demand that they come to an R, right? What is your plan? If you haven't gotten blood samples yet, well, what is your plan then? Like, so there's time for production and time for education, right? And There's a great podcast on learning on shift on EM cases, and how to and also this Judith Bowen article about how do you educate someone on S-bar techniques and on shift. It's great. You have to think of these those long things, lots of it's a lecture in and of itself. I've done lectures on this before, on the neuro lecture part 2. But in general, you try to ask divergent questions, right? You try to don't ask don't pimp questions what is the statistics of this and this and this. Ask okay, so try to use the forcing strategies. Give me 3 dangerous differential diagnoses, right? Make the 2 times 2 table and give me the 3 differential diagnoses that are dangerous here. Yes, that is, and have you made a good workup for these? Non-judgmental, just have you done that? And if they say yes, okay, good, and then then you have your answer. If I believe that's a good workup as well. I cannot come up with other because then you kind of teach them how to do this instead of then you teach them thinking whilst doing it. Scott Weingart has a good point here, where he also once you've done the S-bar, then he will kind of summarize it for the learner, summarize it in 2 or 3 sentences. Okay, so you've seen a patient who has this and this and this, 79-year-old patient with chest pain who has ECG changes, and you want to send them home. Just again, non-judgmental. Just try to summarize it for yourself. Does that sound good? And if it sounds good, then great. If it doesn't sound good, then okay, do you have an argument for why we're doing it like this? Okay, so yeah. Okay, that's just some tips. Here's some pearls from the EM Cases podcast there. Ask open-ended questions. Ask, oh yeah, I forgot. Forcing strategies is important, right? So, all right, so you have your sometimes they can only come up with 1 or 2 differential diagnoses, and you use your 2 times 2 table, and you say, oh, this is they might say, oh, this is gastritis on a 80-year-old, right? Okay, sure, it could be gastritis. It's the most common usually, but are there other differentials that might be more dangerous, right? That's one. Give me 3 dangerous. That's one forcing strategy. Another forcing strategy is okay, so sometimes they would be really sometimes you have a learner who's really anxious of sending someone home, even though they've done a good workup. Okay, so tell me, what are the differential diagnoses? Okay, those 3. Okay, so are there anyone left? No, but they have this bad feeling about it. Maybe they think the patient is looking sick, and they are conscious of their own, they don't know all differentials, and so on, they're humble. But sometimes that humbleness comes into anxiety, and they can't decide. So it's important to try to guide them in that. And okay, so now you've done this test, and the probability begins with 100%, and you think these how the dangerous conditions, how much is that? Maybe 20%. Okay, so there's 80% chance that there's something different. Of these 80% that we haven't worked up, are there anything dangerous in there? And oftentimes they can say no. I don't think so. Okay, you can admit someone on just feeling. If you have a stoic patient who never comes in, has headache, and it's not the worst ever, but they come in with a headache in the middle of the night, then yes, then that might be a thunderclap headache, even though they don't say they have a BAS of 10. But yeah, so you can have that, but in general, you have to make a decision, right? Ask what is, good. Right, so here was the EM Cases blog teaching on shift. Here's this great paper by Judith Bowen, Educational Strategies to Remote Diagnostic Reasoning. And here's this Simon Carley, Can We Teach Clinical Judgment, about how to teach these things about Gary Klein's System 1. Shadowboxing is, and when you have a resus case, try to just see the patient and not look at a monitor. Is it LSS 1 or not? Why not? Usually it's because they were sweating, or they look in a bad way, or yeah. So that's some of the ways that our clinical teaching points. All right, to end all of this podcast, I'll just talk about the CT paradox. a lot of these things are something that I talk about in the overdiagnosis thing, in the overdiagnosis video. But in general, if you like, crowding is not only patients crowding, it's also utilization of our CT scans and all of these things, right? So we can't order CT scans on everyone, but we have been in the last couple of maybe 10 or 20 years, the CT scans have just gone up and up and up, but the mortality has not gone that much different, right? We haven't earned a lot by just doing all these CT scans. And there's lots of problems and lots of reasons for this that we've already been through, like crowding. We need to keep the flow up, and that's why. And people have to like seek on day one. And when they seek on day one and they're in the emergency department, it's hard to say no sometimes. And because doing a CT scan is often better, just not it's time not spent seeing the patient because you can do other stuff. Whilst there's lots of reason why, right? And I've talked about earlier as well in one of the lectures called When the CT Scan Lies, about how important it is to give your pretest probability assessment to your CT scan radiologist, because otherwise they will not be able to they are not machines. They are diagnosticians or probabilisticians, just like we are. They have some kind of systematics on each scan, but they will look like more specifically on depending on what kind of questions you have for them, right? And oftentimes you will do a totally different scan as well on depending on which kind of questions you have, right? So it's really important to write a good pretest probability for them in their so they know what it is they're looking for. There was a great series in the Swedish sjukhusläkaren about this, about how many CT scans that we're doing, especially CT scans of the head and the abdomen. And I agree. And here's what you can see with the statistics, that CTs, especially of the head, after 2011, something happened there. It just went up here in Sweden, and the same with abdomen and pelvis and spine, right? Some of the others have also gone somewhat up, but not as much. I could imagine that if you'd have COVID with us, then you'll. Sorry, this is not Swedish, it's northwestern Australia, but in general, we see the same trends in Sweden, right? That is the CT abdomen, pelvis, and the head. Chest probably during COVID went up, and it has an impact of that. So why? Well, there's lots of reasons why, but I already mentioned some of them. But some of this, like, we can't just wait and see admission. We can't admit patients just to wait and see anymore in the same way that you used to. Because I mean, there's no, like, it's always like, there's this quote from the article in this magazine that I just show you, that, well, it's it's always easier to, or it's also always cheaper to do a CT scan than have a than buy a than have a bed in admission of a patient, right? So the admission costs more than a CT scan. Oftentimes that's maybe true. I don't know. I don't really care. Or I don't care like in the individual case. I care on a system level. It's an important discussion to have, especially while we're going down in beds. And I don't want to add on a lot of work to my colleagues in radiology. I don't want them to think I'm stupid or lazy or anything either. But usually there's a reason why, like this mindset of why is someone good doing this? I think it's important to start there often, instead of doing tribalism. Oh, there's stupid emergency physicians, right, doing this. And most radiologists are doing that. So as we said, it's also freeing up time. Like I can see many more patients if I'm not the test. If the CT scan is waiting, then I can do many more things. Diagnostic creep and indication creep. So we talked about what is a pulmonary embolism in the 60s and what is a pulmonary embolism today. And we have a lot of these clinical decision rules. The test is much better than the is seen object, like CT scans and blood samples are seen much more objective than or they're seen as more objective things than the subjective meaning of a physician. And there's more variability, and people are not yeah, Jerome Hoffman has talked a lot about this, right? So, uh, in a zero miss culture as well, we are trying to find smaller and smaller diseases, and overdiagnosis is becoming this big problem. So, lack of knowledge, of course, that is also a problem, right? We do CT scans instead of communicating with the patients. We might not have follow up. The Lyon system is Lyon principle, where the ED is the default. It would be much better. Like if we didn't have the CT scan right next door, if it wasn't that accessible, then it probably would be easier for, like, when the patient. If you see the same patient in the primary care physician kind of setting, then you probably wouldn't send them to that many CT scans as we do in the emergency department, because it's the different thing, right? Once they've come over our threshold, it's really hard to get them out, so to speak, in a good way. And oftentimes, I mean, and then there's incentives for primary care physicians to send them so that they don't live up to the Lyon principle, especially here in Sweden and Stockholm. But yeah, pressure on private practice to work up conditions in timely manner. Yeah, they often go to the ED here in Stockholm instead, and often not because of the, like, it's not the primary care physician's fault. It's just how it is. Their incentives are not big enough. Need for certainty. We talked about the risk proximity problem, and Jerome Hoffman's and Simon Colley's arguments for this. You can check out Simon Colley's book about risk proximity, or Jerome Hoffman's blog on overdiagnosis and the fiduciary problem. I've talked about that for a long while as well. The big ones are risk illiteracy as well, and fear of mortality in society. I think we want this perfect society where it's not allowed to miss anything, where it's not allowed to die, and where people, in general, also doctors, don't know what the harms and benefits are of many scans. We know that from studies, right? Or of many examinations, of many treatments, right? We have a hybris sometimes of thinking what medicine can do and what it can't, right? And we have a risk illiteracy. This is Gerd Gigerenzer from the Hardinger Institute in Berlin, who's made books about this, and Simon Carley has talked a lot about him as well. How we don't know how to assess risk, and many people would do a CT scan. Many people want to have zero chance of anything, right? And we all want, but that's impossible. So we have to inform them. But if we as doctors don't know how to inform our patients, then it's really hard to convey, like, these complex, or these kind of complicated themes, like of overdiagnosis and all, for our patients in the small amount of time that we're seeing them. Our fiduciary duty is, however, to the society. Like, I often do this fiduciary talk that Jerome Hoffman talks about. Like, our responsibility as physicians is to have the patient's interest as our prior one, right? And the patient's interest, like, and not our own interest. So my default is easy, just to order a CT scan, order a test, or just treat. That's the easiest thing. The reason why I'm talking with you about this, the reason why I'm even bothering, is because I want you to have the best outcome possible. I try to care about you, and I often try to meta communicate this, like try to say it out loud. This that's why I'm trying to not do the CT scan. And oftentimes I would rather not. I would rather sleep at home and see how it happens. Instead. But it's like, when, as Justin Morgenstern says wisely, if you do this kind of shared decision making kind of thing, and then you really have to bring the CT scan to the table. Like, the patient can say, no, I don't want to listen to it. I just want a CT scan. So it's hard. It's a hard place to guide yourself into here. But I think usually they listen. Yeah, and why else? Like, well, guidelines and clinical decision rules have made us, like, we need to do a lot of CT scans because of those. Even those clinical decision rules say that they try to reduce them, they don't. Oftentimes, you can try to check out Justin Morgenstern's blog on this. There's no evidence most of the time that they reduce things, and usually they're not externally validated. Clinical decision rules are a good idea for some problems, not complex problems, but complicated problems or simple problems. Yeah, check out Justin Morgan's blog on why clinical decision rules are ruining medicine for a more nuanced take. And then crowding, of course, is also big, and it's also it's like a positive feedback loop, because more crowding yields more CT scans, yields more positive findings or false positive findings, incidentalomas, which is more workup, which is more crowding. So it's like a positive feedback loop that is horrible. Yeah. Die Wise, a book about why we are death illiterate, and by Stephen Jenkinson. This is not the only book about this concept, but I think he's saying it quite well, that we are death illiterate, and we should probably think more about how death is part of life, and be grateful for what we have. I'm not preaching. Sorry, I think he has some great ideas that kind of should be taken into account in our society. Yeah, and the fiduciary argument I've talked about in the overdiagnosis block. So like drivers, what drives this that we want to just do CT scans and do too much medicine? Earlier is better. That's a myth most of the time. I believe in the test more than the clinician, and we think that it conveys. It conveys quality of care. I usually do a POCUS instead, to kind of reduce the CT scan use. Just the calming POCUS scan, as long as you know, like you do it kind of roughly, so you don't find incidentalomas or anything like that. More is more. Also, a myth is sometimes more is more. Like the over medicalization BMJ podcast will talk about this as well, and my overdiagnosis blog as well. They want to know exactly what is wrong, but usually the time as a test is better. You don't want to diagnose it day 1 or day 2 if it's not obvious, right? You want time to go on, and you want nuances in your diagnostic workup. On diagnosis doesn't matter if you don't, like most things are rough and tumble of life, right? So time as a test is the best, as long as it's not dangerous. Fear and fallibility, culture of blame, yeah, that drives overdiagnosis as well, right? Must know how. Readily available, highly sensitive tests. Yeah, we have 2 sensitive tests, 2 readily available on day 1. It's much better to like have some kind of sieve or sorting function where you just see a primary care physician and then see whether you need to be seen in a week or so or not. If it doesn't go over, then come back, right? But people don't have the what do you say? Well, in a closed system where you have just one primary care physician, or like several, but they all know you, kind of, then you can, like, my dad's a primary care physician, and one of the things he usually said, like, is this, like, it takes 10 minutes to tell patients why they shouldn't have antibiotics. It takes 5 minutes to prescribe it. If you want to invest those 10 minutes, then you have to know that that patient is coming back, right? Because then you're kind of investing time in that you might win later on, right? If you have to talk about, you have to use 10 minutes every time and losing those 10 minutes every time because they want to, and like you might convince one, but they will not know it the next time around, and then it's just a problem, right? So then you might not be willing to invest that time. So yeah, expanding diagnosis definitions, yeah, creep, and we talked about hijacking medicine by Ioannidis and his legendary articles on that. Yeah, and what we're doing actually when we're not, then we're trading our best with the patient's best. Our fiduciary is falling apart, and it's really hard. I don't blame anyone. It's just that this is a complex problem that we're seeing, and we have been seeing. And yeah. All right, I think this is the last slide actually in this 4-part series, and this was a great pleasure to just summarize some of these things as that you might need as an emergency physician. You can see this 9-hour block or video whenever. But it's a good reference point to go through, especially if you're starting off or haven't heard about these concepts before. Then yeah, thank you so much, and bye bye.